So will PMOS being treated outside of just gyno or reproductive health mean more research, more funding, more care? Like on one hand, I hope not, because that's very upsetting and it shouldn't require that kind of reframing for it to be treated seriously. But on the other hand, like I hope so, right? It's a kind of a catch-22. The name is better at communicating the scope, polyendocrine, metabolic, but the name itself doesn't automatically fix care.
Sure. Hello, everybody, and welcome back to the How to Fitness podcast with me, Michael Ujoa.
And me, Kate Lyman.
And we're back today with the Kate Lyman deep dive. We've just been discussing our toddlers and their antics, which has been very funny leading up to this episode. But Kate, how are you doing today?
You know what? I'm fine. I'm fine. I'm really excited about this episode, Michael. I'm also like a little nervous about it. You and I always get a little nervous.
Yeah. It's like excitement
and
nerves.
I think it's excitement nerves. Yeah. It totally is. It's excitement nerves. But before we get into it, can I share with you and our listeners something so revolutionary? I didn't share this with you before when we were chatting because I wanted it to be fresh. I have a really big fear of things touching my eyes. Okay. Like that's a fear. Like,
yeah, that's like, a lot of people do.
Yeah, it's really normal. But I've never been able to like wear eye makeup or touch my eyes in that way. And I have slowly gotten over that, and I've used an eyelash curler, and I can see better.
Because your eyelashes are out the way.
Literally, I can see, I have to say, a 20% increase in vision.
Wow. Is this like a common thing?
I have no idea. Listeners, tell me. Sure. Yeah. So I have I have dark hair, dark eyelashes, but they like kind of go straight down. Like there is no natural curl. So I've always been like, it would be nice if these were a little out of the way.
As soon as you say that, is it like the mammoth from Sesame Street that has really long eyelashes?
Yeah, Snuffleupagus. Exactly. Exactly like that.
Kate now has a new nickname in my phone book.
Snuffleupagus, yeah. Or Snuffleupagus, I don't remember. Anyway, I'm sitting here and I'm looking at my script, and this has been like the last 3 days. I've like reached it's like when you get glasses for the first time. I was like 8 when I got glasses for the first time, and I was like, what? People can see like this? That's actually how I feel. So anyway, that's like really exciting news for me.
This is good. Your eyes always look great, Kate. So I'm very impressed. There we go. Compliment. My wife Emma, she uses one of the eyelash curlers too. They freak me out. Just the way they look is quite terrifying.
Torture device.
Yeah, I get it.
And it's not like I'm using that easily. I'm like hyping myself up. I'm like, this is gonna be worth it. Yeah.
I'm proud of you, Kate. Well done.
Thank you, Michael. Shall we talk?
We probably should. People probably want to hear something fitness related.
Yeah.
Thank you so much for listening, everybody. We always appreciate all the reviews, all the comments, all the shares to support our little podcast here, How to Fitness. We receive so many lovely messages from really dedicated listeners, and we love it so much when people engage with these episodes, and we want more and more people to hear it because we think we provide really solid value. So if you find that these episodes are helpful, if you think anyone you know would find them helpful, please do leave a little review or give us a share. We would love you forever.
Forever and ever. Seriously, You make our day. We're going to talk about this recent name change from PCOS to PMOS today. And if you're already like, what are you talking about? We're going to get into it, and you're going to learn more than you ever thought you'd learn from How to Fitness about PCOS, now PMOS. And we're going to, I know that this topic is not as widespread as others we have talked about, right? Mm-hmm. So I've done my best to make our episode today touch on a lot of different aspects of women's health, reproductive health in general, insulin resistance, and some other topics medications, some other topics that I think are more applicable to everybody. And we're going to kind of wind our way there. So are you ready for this journey?
I'm excited. I am so ready. I genuinely, I'm really excited to learn about this name change. And I've read like a little bit about it, but I don't know much at all. So I'm excited for this one, Kate.
Cool. Well, I know too much now. Just kidding. I know as much as we should all know. And that is, I did learn a lot in this episode. So let me start by reading a super upsetting quote for you, okay? Women's reproductive organs are preeminent. They exercise a controlling influence upon her entire system and entail upon her many painful and dangerous diseases. They are the source of her peculiarities, the center of her sympathies, and the seat of her diseases. Everything that is peculiar to her springs from her sexual organization. From Dr. John Wiltbank in his introductory lecture in midwifery in Philadelphia College in 1853.
I don't know what face to pull whilst you read that to me, Kate.
That was a good one. Like you ate something gross. Okay. That was a good one. So we're here to talk about the renaming of PCOS to PMOS. And last week, a Lancet paper came out about this groundbreaking name change. And I had actually been starting to prepare an episode around inflammation. And I had this idea about a different episode about insulin resistance in my back pocket. But this name change kind of pushed me to put all that aside and focus on this episode right now, because I think we can learn a lot from it and set a lot of foundation that helps us navigate this world of wellness information a lot better. So before we get into the name change, Michael, that lovely quote by Dr. Wiltbank given at a lecture in midwifery about the peculiar disease-ridden sexual reproductive organs of women is the first quote I pulled when I decided on this episode. And I read it a few years back when I read the book All in Her Head by Dr. Elizabeth Coman, a book I know I have shared on the pod in the past because it is so good. I encourage anyone and everyone to read it. It is about women's health and how so much of women's health has historically and is still being overlooked, and how many women are being told it is all in our head when we're dealing with real medical struggles. So today we're going to talk about the PMOS name change, and we're going to talk about PMOS in general, signs, symptoms, misconceptions, treatments, and more. But I don't think we can have this conversation without it also being about how women's health has been historically stigmatized and under-researched.
Massively.
Massively, right. So a quick note before we dive in, I've seen a range of estimates about the prevalence of PCOS and PMOS, and the 2023 International Evidence-Based Guideline for the Assessment and Management of Polycystic Ovary Syndrome, PCOS, estimates that 10 to 13% of those with ovaries have this condition, but that it's also underdiagnosed. Did you know that many people have PCOS, PMOS, Michael?
I did not think it was that high. I knew it was a quite high number, and it always surprised me that, maybe it didn't surprise me, the lack of research into it, but I did not think it was that high.
Yeah, it's pretty significant, and I've seen estimates of up to 18% of those born with ovaries. I mean, it's all over the map, but it's a lot. It's a lot of people. So let us first talk about this landmark change. We are recording today on Friday, May 22nd. So 10 days ago, a paper came out in the Lancet announcing an unprecedented name change from PCOS, polycystic ovary syndrome, to PMOS, polyendocrine metabolic ovarian syndrome. Now, names of conditions have changed before. This is not a new thing that a name of a condition has changed. But the part that was a bit more unprecedented was how this name change was made. It was a rigorous global consensus that engaged patients and health professionals and organizations worldwide over the span of 14 years. It was a very comprehensive change, and it wasn't perfect. Like, there were, of course, some gaps in who was involved in the change, but the Lancet outlines the process very clearly, and it shows just how important the push was to make sure that the new name encompasses the endocrine, metabolic, reproductive, psychological, and dermatological features of PCOS, now PMOS. And in this process, 86% of the participants voted to adopt a symptom-based name. So we need to pause and talk about what PMOS, the artist formerly known as PCOS, or the platform formerly known as PCOS, that's what goes through my head every time now, actually is, because it makes the name change make a hell of a lot more sense. And before we get into that, I'm just going to give a quick note that, like, so much of medicine works within a binary, right, of male and female. We know that that's such a simplified way of looking at sex and gender. For consistency and cohesion throughout this episode, I'm going to use the word women when I talk about PMOS, but I know firsthand that there are many who identify as men living with PCOS. I actually work with a few through my work with the Out Foundation. So I totally understand that. And I'm going to do my best here. But PMOS is a condition where the body's hormones and metabolism interact differently, often affecting ovulation and androgen levels. And that can influence everything from periods and acne to long-term blood sugar and heart health risk. The previous name, polycystic ovary syndrome, implied that it was a condition based around the pathology of ovarian cysts. And that right there is our first sticky point, because ovarian cysts, they're a real thing, but they are not a part of PMOS. It's a total misnomer. The diagnosis of PMOS comes from someone assigned female at birth having two of the following three conditions, according to the Rotterdam criteria set in 2003. So this Rotterdam criteria is that someone for a diagnosis of PMOS must have two of the three following, meet two of the three following criteria. So the first is polycystic ovarian morphology on an ultrasound. This refers to the specific appearance of the ovaries that look like cysts, but are not cysts. So what's seen on the ultrasound is often confused with cysts, but it's small antral follicles, which is small fluid-filled sacs that contain an egg that have not fully developed to release an egg during ovulation. So in PMOS, the number of antral follicles increased, and having more than 20 denotes this, quote, polycystic ovarian morphology. So there are no cysts. There's just something that look like cysts that have been named cysts, but aren't. The second thing, the second criteria is chronic irregular periods. So periods usually occur, about once a month, but in PMOS, periods can be less frequent, which is called oligomenorrhea. We're just going to leave that in.
Yeah.
Or not at all, which is amenorrhea, which I can say much better. So this is where kind of the infertility piece of PMOS lives. We'll get to that in a moment, but I'll just quickly say that having PMOS does not make someone infertile. It is harder. It could be harder to get pregnant, but that's mostly because of this irregular ovulation. The third thing is hyperandrogenism, which refers to high androgen levels in the blood. Now, androgens are hormones such as testosterone and several others, but we most correlate this with testosterone, which if too high can cause symptoms such as excess hair growth, which is called hirsutism, and cystic acne or normal acne. This can be seen with a hormone test, like a blood test, or it can be clinical, meaning we don't have to test for it. You can see that someone has hirsutism, which is kind of like coarse hair growing in male pattern areas that could be chin, underarms, elsewhere on the body, acne, or hair loss on the head. Again, it's a lot of like male hair patterns.
Sure.
Now, remember that I said the diagnosis or classification of PMOS comes from having two of these three conditions. There are different phenotypes of PMOS depending on the combination of these diagnostic criteria. And so these different phenotypes correlate with things like higher prevalence of insulin resistance, with phenotypes A and B being the most classic form. If you're watching the YouTube, I'm going to put a little graphic up here so it gives you a nice visual. But this variety of phenotypes means that someone could have PMOS and not even have that appearance of polycystic ovaries, the ones that aren't cysts at all. But of all of the diagnoses require either clinical or biochemical hyperandrogenism or irregular periods. So I could not fit this into this episode, but if polycystic ovarian morphology is not required for this condition, it also means that there is found a male equivalent of PMOS in men, right? There's studies dating back to 10, 15 years ago talking about this. It doesn't have an official name. It doesn't have official diagnostic criterion, but this is a pattern that can exist for those with testes instead of ovaries, which is really interesting because I think, well, maybe you can answer this for me, Michael. It feels very much an area of women's health and women's reproductive health, right?
Yeah, absolutely. Yeah. I'd never even heard about that being a possibility for men as well. So, yeah. So it's a whole rabbit hole someone could go down. I welcome you to do that, and we'll talk about it. So
I know that we're using some big words and this feels pretty clinical. We're going to move past the clinical stuff. But the point here is that the diagnosis of PMOS requires that there must be evidence that your body either produces different levels of hormones than women without PMOS, or that it responds differently to those hormones, or both. And so there's a cascade of metabolic effects that stem from these hormonal effects of the condition. It's not about cysts on the ovaries.
Mm-hmm.
I think you'll get a kick out of this too, Michael, because I actually giggled while reading the paper. But one of the top contenders for the name was endocrine metabolic ovulatory syndrome. From the paper, it says endocrine metabolic ovulatory syndrome was considered a really representative name, but the acronym was EMOS and was, quote, found to overlap with the so-called emo youth subculture, in which emotional expression, particularly melancholy, alienation, romantic despair, and anxiety, was central to identity formation.
It's not a phase. I love that so much.
That's
phase. Fantastic.
I was like, I have to say, it was so jarring to be like reading through this paper on my iPad and annotating and being like, wait, what did I just read?
And also just like a little window into your past as well.
Yeah, exactly.
Maybe a little bit still today.
Always emo, never a phase. So I've seen a fair amount of commentary around this name change not actually being a big step forward for women's health. I don't know. What have you seen in commentary on the internet, Michael?
A bit of both, actually. Yeah, I saw more in support of this, saying that they really welcomed the change. And then I did see quite a few videos from people saying that it didn't go far enough. But once again, I haven't delved deep enough into it to be able to know exactly what they didn't think was going far enough around it. But yeah, it was definitely mixed.
Yeah, I've seen the same. And I read a really interesting Substack article from one of the dissenting votes. So there were 3 dissenting votes out of I think hundreds of affirmative votes on the name change. And it was interesting to read her perspective. And part of it was she had built her business and life and work and research around PCOS, and the cost to change it is really prohibitive, right? And she was saying, okay, we can change it all, but does this change anything? And you know what? No, if it doesn't come with more awareness or care quality or research or policy and advocacy, it is kind of pointless. We're just hoping that it comes with all that, right?
Yeah. There's always hope, but we know how underfunded women's research is, that the expectations are pretty low, unfortunately.
Exactly. And I think, it's a darn good start, I guess, because PCOS was woefully named and that feels inarguable. Once we recognize, this was never about polycystic ovaries, you don't need cysts. Cysts on ovaries are completely different. That it makes it kind of a no-brainer. But a quick note as well is this name change doesn't denote us learning anything new about PMOS. This change isn't happening because we just learned that PMOS is linked to insulin resistance. We've known that. And something that I have seen in conversations online that, oh my gosh, Michael, the way it makes my blood boil is fitness, wellness type coaches being like, see, I've been saying this all along. And I'm like, okay, read the paper. You haven't read the paper. The Lancet paper stresses over and over and over again the importance of nomenclature that actually accurately describes the condition and the need for an accurate name to, quote, enhance awareness, diagnosis, care quality, research coherence, and patient experience, strengthening policy, advocacy, and health outcomes globally. So some context on where it stands right now is this name change is expected to take place over the next 3 years. I've seen some folks use PMOS right away and others stay with PCOS for the time being.
I was going to say about that, I wonder how quickly that shift happens, because sometimes you see old names for conditions sticking around for a long time.
Yeah, it should be 3 years. Everything globally should be shifted over, including international guidelines. I
was just wondering if I don't know if it's along the same lines, but when we listen to Dr. Jen Gunter talking about HRT, and they don't want to call it HRT anymore, but everyone still refers to it as HRT. You wonder how. I
think of that example specifically, with menopausal hormone therapy replacing hormone replacement therapy, as a lot of it is on us as if we
Mm.
want to call ourselves practitioners or leaders in the space to use, because people will follow the lead.
Yeah, that's fair.
I am struggling to say PMOS because I think I'm just defaulting to PCOS.
Agreed.
But neither roll off the tongue.
Yeah, fair. Yeah.
And like, are we saying PMOS? I don't really like that either.
If they stuck with emos, we could have easily remembered it.
Emos. Honestly, it should have been emos. All right, Michael, I have a quick quote from the Lancet paper that I'd love for you to read.
Absolutely. Perfect. So endocrine and metabolic terms were supported. However, consistent concerns arose around the reproductive term. Although accurately aligned to genetics, pathophysiology, and clinical features, the potential for the reproductive term to cause social stigmatization and harm in some cultures or world regions was recognized. Alternative terms such as ovulatory were felt to be less stigmatizing, but did not encompass broader reproductive features or extend beyond menopause.
So there was a very specific push to not let the word reproductive enter this new name because of the stigma.
Interesting. Okay.
And that feels sad. And what that brought up in my mind when I read that was like, I think someone reading this, when it says the reproductive term could cause social stigmatization and harm in some cultures or world regions, I think our brain might go to, quote, developing countries. That's a problematic term, but you know, like, but I'm from the United States. It feels pretty clear to say reproductive medicine and reproductive health, specifically women's health, is very stigmatized, and care is very not guaranteed there. So I thought that was a big step. And there's a quote from Dr. Elizabeth Coleman in this book, All in Her Head, that again, I just love so much. I have like half the thing highlighted, that says, of all the systems the human body contains and of all the areas physicians seek to treat, the female reproductive system remains the most misunderstood and plagued by biases that have been woven into the fabric of medicine for as long as medicine has been practiced. And that's true in that horrific quote we wrote right off the bat, right? It's like women's reproductive system is the fountain of all her disease and peculiarities, or whatever. Mr. Dr. John said.
Mr. Doctor.
Yeah, I think it's very fair to say reproductive health has historically been viewed as stigmatized and taboo. And I think it feels safe to say also that since the beginning of time, medicine has treated women's bodies as mysterious or unknowable, and women do get decentered in conversations around their own care. You know, I wrestle this, Michael. I don't want to just like be an angry girl on the podcast.
I want you to be that.
But I have a lot of big feelings. I also feel very strongly about this, and I have a little personal stake in the game. I've shared this on the podcast before, but I'm someone who's suffered from significant birth injuries and pelvic organ prolapse for the last 3 years. And I have found care and information woefully inadequate. And when we look at the population of the world, about 50% assigned female at birth, and we say, oh, we don't know everything about our reproductive systems. I mean, come on. So
I always love, you're always kind of fighting against that that tagline of being angry woman on the podcast, and I'm always like cheering you on, like, more, Kate, more.
Yeah, I know. We balance each other out because I'm trying to hold back often. So, you know, this name change hopefully centers PMOS more around the endocrine and metabolic systems. So step in the right direction, we can hope, because here is where our knowledge of our current knowledge of PMOS stands. In my research of this episode, I read so many accounts of doctors recounting their training in PMOS in med school, or their lack of training rather, and this perpetuated misconception that it was a condition of women who wanted to get pregnant but struggled to. And I read other accounts of how medical textbooks portrayed those with PMOS in the past, women with larger bodies and facial hair and acne. And the manifestation of what PMOS, quote, looks like is so broad, but it seems to be historically described in similar ways. Michael, I have another quote for you. I'm sorry I gave you, wait, no, the first one was good. This one's a little unfortunate, but I want you to read this excerpt from Hippocrates in his writings of Diseases of Women back in approximately 400 BC.
But those women whose menstruation is less than 3 days or is meager are robust, with a healthy complexion and a masculine appearance. Yet they are not concerned about bearing children, nor do they become pregnant.
Yeah, there is so much of this. I can read it over and over and over. I'm not here to like whine about Hippocrates, but I'm going to say that what he said centuries ago mirrored what doctors said hundreds of years ago and decades ago and right now. Because when we talk about stigma around PMOS, a huge amount of it comes down to how these symptoms of PMOS can violate gendered norms or expectations of what it means to be feminine. There is talk of the robust masculine characteristics, the bearded woman, the large frame, all of that. And we can see this stigma play out in real care settings in a lot of really predictable ways.
Which is wild when you said like up to 18% of women might have this condition as well.
Yes.
It's like, this is really normal.
Yes,
maybe normal. Like it should be normalized. Absolutely.
Well, it is normal in that there is no one body with one hormonal profile and one look that is normal, right? Like there's so much variability in our human bodies. And so to put all of this in all of these different hormonal and metabolic complications into it looks like this is so wrong, so skewed, so flawed. So we see the stigma play out in real care settings in some predictable ways. First, fertility is often the main lens of diagnosis. If you're reading about PMOS, you'll see a lot of focus on fertility. And in real life, a lot of people report that patients are taken seriously only if they're trying to conceive. And if they're not, the conversation might end with like well, we'll worry about it once you want kids, right? Second, cosmetic symptoms are often minimized. So the hirsutism, acne, hair thinning, these are often treated like a vanity problem instead of a medically relevant sign of androgen activity, right? It's not a cosmetic issue. It is a sign of something going on in terms of our endocrine system. And third, and this one I know that you know acutely as well, Michael, a sole focus on weight. So weight is often treated as the only issue. Everything gets routed back to weight loss before labs, before symptom management, before screening, et cetera, et cetera. It's come back if after you've lost weight. And I want to say very clearly, like the last one isn't just frustrating. It's like care being withheld from someone until they lose weight. And a diagnostic delay because someone needs to change their quote lifestyle first is ridiculous. I think, I'm simplifying a little bit here, but these examples are kind of an amalgamation of personal experience I read over and over and over, and I've heard from my own clients. And to be fair, the most recent 2023 guidelines around PCOS, now PMOS, do try to correct a lot of the weight stigma that has historically shown up around diagnosis and treatment. But all of this stigma has very real downstream effects. It delays diagnosis, reduces follow-up and screening. It can drive some shame-based behavior change attempts that increase stress and weight cycling and disordered eating risk. In a paper called Delayed Diagnosis and a Lack of Information Associated with the Dissatisfaction in Women with Polycystic Ovary Syndrome in the Journal of Clinical Endocrinology and Metabolism, we see a report of 1/3 or more of women reporting a timeline of over 2 years before a diagnosis was established, and nearly half reporting needing to see over 3 health professionals before getting a diagnosis.
And I think we all know someone who's been through that whole process before. I've had friends, family members who have been through this process before, completely being blamed on weight loss, like lose weight. And then years later being like, oh, actually, you've got PMOS. Like, duh. Like, it's just so
and they're
frustrating.
like, I've been telling you that because I live in my body and I understand what my body is doing. And I know that my lifestyle is incongruent with what I'm seeing or feeling or experiencing. Yeah. There's a myriad of reasons why PMOS is underdiagnosis, why diagnosis takes such a long time. And a lot of it is the stigma we're talking about. And a lot of it is because it's seen as a reproductive issue or a gynecological issue or a woman's issue that is made for less awareness. So will PMOS being treated outside of just gyno or reproductive health mean more research, more funding, more care? like on one hand, I hope not, because that's very upsetting and it shouldn't require that kind of reframing for it to be treated seriously. But on the other hand, like, I hope so, right? It's a kind of a catch-22. The name is better at communicating the scope, polyendocrine, metabolic, but the name itself doesn't automatically fix care.
Sure.
And I think a lot of the dissenting opinions you and I have seen online are saying just that. Like, okay, cool name change, but what about care?
Yeah.
Right? Now I want to kind of swerve into some of the complications of PMOS and the little we know about causes and how we approach, quote, treatment. Michael, do you know what causes PMOS?
No, I do not.
Well, no one does. So
Okay. Phew.
correct answer. We can obviously see cases of PMOS, formerly PCOS, as far back as ancient Greece. Thank you to Hippocrates and his kind words. But there's a mostly genetic component. That's what we know. There may be also some epigenetic components, but that's outside of the scope of what we're going to talk about right now. Something else we know is that PMOS is more common in people from minority ethnic backgrounds and disadvantaged socioeconomic groups, which I think helps us acknowledge this isn't biology only, right? This is also care and diagnosis patterns and environmental stressors and social determinants. Now, it's estimated that up to 70% of women with PMOS worldwide do not know they have this condition.
Wow.
Yeah, that's a lot. And there's obviously this issue of gaps in provider knowledge at play here, but there's also the reality that signs and symptoms for individuals vary so much person to person and can change over time. So possible symptoms include some of what we've already discussed, intermittent or unpredictable or absent periods. For some women, it can also look like heavy or long or painful periods. Difficulty conceiving or infertility. An estimated 90% of women who experience female infertility due to anovulation or the disruption of egg development and release also have PMOS. Again, fertility is just one possible impact, not the whole principle, but excessive hair on the face or body, female pattern baldness or hair thinning, acne or oily skin. And just a quick yet important note that a lot of these symptoms are not only specific to PMOS, right? Like that it could be someone else could have something going on and experience these. But this is the part of PMOS I think we often miss. More than half of women with PMOS will develop type 2 diabetes by the age of 40.
Wow.
That's significant. Women with PMOS experience 19% higher risk of developing cardiovascular disease than women without. And the odds of depressive disorders are 5.7 times higher for women with a PMOS diagnosis as compared to those without. Those are significant health complications. So someone with PMOS has an increased risk of developing hypertension, high cholesterol, sleep apnea, metabolic steatohepatitis, which is a very hard word that I learned used to be called non-alcoholic fatty liver disease. So apparently that's changed.
This is what I mentioned, like old names still used. We didn't even know they changed.
Exactly.
Yeah.
Endometrial cancer, and then already mentioned depression and anxiety. So the Lancet paper does share a lot about these different manifestations of PMOS, from insulin resistance to the cardiometabolic complications and mental health as well. So while we're often generalizing about the hirsutism or infertility, we cannot look at these other long-term risks of PMOS, which are often like kind of overlooked in favor of the more surface level aspects of the condition. There are some significant long-term metabolic risks involved. Did you feel as clued into that fact, Michael?
No, like I knew that they were a higher risk. I didn't realize it was as significant as that. And then I'm assuming with that 70%, do a lot of them then find out after they've been diagnosed with other health complications, or they just never find out? They just assumed that it's lifestyle habits, or it's your fault because you've not looked after yourself, that kind of thing.
I would think it depends on location, right?
Yeah, fair, yeah.
And what your provider network is looking like. But if you've read, have you read the book Invisible Women?
No.
By, her name starts with a C.
Like I should, and ironically,
it's really good. It's a lot about, disparities in women's health research, but also it's disparities in women being involved in research in any aspect. It's a very good book. It talks about how like seat belts are designed for male bodies, and that's why women die more in car crashes. But it talks a lot about women's health research as well. And as does All in Her Head, women are at risk of cardiovascular health issues, heart attack, stroke, etc. But it's often seen as like a man thing because the manifestations look different. So I think this is another branch of, that's also really relevant here.
I'm adding both these books to my reading list, and I know people listening will be like, he won't do that. I will. I promise I will. I'm like 4 months out of finishing my master's, and I'll actually have time to read books again,
put it off
which I'm so excited for. Yeah.
Do you know what you have also told me to read Men Who Hate Women by Laura Bates, and I have yet to get to that. But again, I am going to read it. I just read her more recent book, The New Age of Sexism, and it was fantastic.
Yeah, it's one of those books,
very upsetting.
Yeah, I feel like you have to read it in chunks because taking it all in one go just feels
it's too much.
It's too much. It's overwhelming. Yeah.
All right, so Michael, what's the cure for PMOS?
There isn't one.
Right again. Right again. We don't know what causes, and there isn't a cure. But we do have different ways to treat the individual symptoms and manifestations of PMOS, and that is a good thing. The goals of these treatments are to reduce symptoms, improve quality of life, prevent those long-term complications, the stuff we just talked about. And in my opinion, it's kind of what we could be focusing on rather than some of the more, quote, like stereotypical outward markers of PMOS that aren't necessarily applicable to everyone, right? So Michael, when you got my panicked text yesterday, my customary
24 hours before, like clockwork.
24, exactly. I was just feeling so overwhelmed trying to consolidate all of my research and talk about this topic in a way that felt beneficial for our audience, whether they have a PMOS diagnosis or not. And, I was like wanting to touch on so many different aspects of the diagnosis and the treatments and the myths and misconceptions and the lengthy conversation to be had around medication, et cetera, et cetera, et cetera. And then I thought about a KLN team power hour we had earlier in the year. So I've mentioned these before. My team, we do like a continuing education meetup every month. And several months back, we had one on then PCOS, led by one of my amazing, fantastic, brilliant, wonderful coaches, Whitney. And one of the biggest takeaways Whitney shared with us was how few holistic approaches there are to PMOS and how much of the research we have is very segmented and seems to focus on improving metabolic or endocrine health through specific interventions. So she had given us examples like Tai Chi for insulin resistance or omega-3 for, androgen levels or what have you. So I am following her lead here, and I thought I'd talk about the aspect of PMOS that I focus on most with my clients, which is metabolic health. And to do this, we first need to speak about the common misconception that those with PMOS have a slower metabolism. Have you heard that before, Michael?
Yes.
This is really interesting. I hope I've clung some of your attention and you're still here listening to this if this topic doesn't feel as relevant to you. But there is a study called basal metabolic rate is decreased with women with polycystic ovary syndrome and biochemical hyperandrogenemia and is associated with insulin resistance by Georgopoulos et al. That purports to show that women with PCOS but no insulin resistance have BMRs about 13% lower than women without PCOS, and that women with both PCOS and insulin resistance have BMRs nearly 40% lower than women without PCOS. And this is cited and quoted all the time. But it seems to be an outlier when we look at the actual data in this space. So a few years back, Lee Peel and Greg Knuckles did a fantastic deep dive in their BMR series they were doing into these claims. And what they found is something that I have shared with many of my clients. So
I think, should we just jump in here for those listening who aren't sure what BMR is?
Oh, please, thank you.
Basal metabolic rate, and it's the amount of calories that your body burns at baseline. If you were kind of comatose, not doing anything, it's the amount of energy that calories your body burns completely at rest.
Thank you. Please always do that to me, Michael.
No worries.
So what Peel and Knuckles did is they ran a meta-analysis pooling the data from 444 subjects in 14 groups across 7 studies, all looking at BMR in women with and without PCOS. So how many calories are they burning at rest if they have this diagnosis or not. I realize I'm saying PCOS here because it's what the notes say. When we look at all those studies, the Georgopoulos study tends to be an outlier. It found a negative effect that was more than twice as large than as any other study. So essentially, even with that Georgopoulos study included, the research suggests that women with and without PCOS have pretty similar BMRs.
Interesting.
When you add that study, when you exclude that study as an outlier, the other 6 studies show that women with PCOS may actually have slightly higher BMRs than women without. Mm-hmm. The difference either way is so trivial. So it's not statistically significant at all. Mm-hmm. But they ran another analysis looking at 14 studies in a total of 642 women with PCOS. And across these studies, same thing. PCOS doesn't seem to meaningfully affect basal metabolic rate. The popular claim that PCOS slows metabolism then is based on one highly cited study whose findings are different than anything else we see in the rest of the research.
Okay.
Yeah. So this isn't to say there isn't variability, because there's variability across every single person, right? Like there's so much variability in BMR, but PCOS itself, PMOS now, doesn't seem to appear reliably lower in BMR in a consistent way. So
interesting. Okay.
I will link in the show notes that deep dive where you can, if you want to learn all of the methodological errors, probably a potentially invalidated machine that was used for this study. You could look into that. But I think this is a great thing. To me, it means the way we approach metabolic health can be actionable and evidence-based, and someone navigating PMOS does not have to feel hopeless about this idea like, I'm gaining weight inexplicably. I can't lose weight. My metabolism is, quote, broken. And so that's why we're going to talk a little bit now about insulin resistance. Many individuals with PMOS struggle with their weight, and they may have this unexplained weight gain or higher prevalence of obesity or struggle to lose body fat. And I recognize we're talking about this at the same time we just talked about stigma, that it's all about weight. A lot of times when I see a client who has PMOS, this is the driving force behind why they're working with some nutrition support. And I assume that's the same for you, Michael.
Yeah, it is. Yep.
So often, and I'm not speaking for everybody, but I would say like a majority of those I've worked with, they're feeling broken or hopeless. They've been told they can't lose weight, but also they need to lose weight. And so much of those feelings are due to this stigma or this overgeneralizing around what PMOS actually means. We just myth-busted a bit of that, like this perpetuation of the idea that metabolism is slow for those with PMOS, or that weight loss won't be possible for them. And I think this is where it becomes so important for our focus, for coach and client and listeners and practitioners and whoever's involved in this conversation, for our focus to be on metabolic health. There is no specific diet that has been shown to be superior to others in the management of PMOS.
That's not what I saw on Instagram, Kate.
Oh, I'm here to crush your dreams or make them better. I don't know. Like, I think that's a good thing, right? I don't know. It depends. It would be nice to have just like a prescriptive, like, here's what to do, right?
It would, but I mean,
I kind of do have that hang tight.
I know. Any condition though, they're willing to exploit it because people suck on Instagram. Yep.
Absolutely. Any healthy diet that suits a particular individual such that they're able to be able to stick to it longer term to help with weight loss is beneficial for PMOS, as is movement. Mm-hmm. So to focus on metabolic health, prioritizing evidence-based strategies to reduce the effects of the insulin resistance that's really common in those with PMOS is usually the most effective approach. And I get that that can feel like kind of a letdown, right? Like, because addressing insulin resistance isn't specific to PMOS. It is, however, the most practical leverage point in this feedback loop to target. Insulin resistance is present in 70 to 80% of women with PMOS. That's a lot.
Mm-hmm.
I think those who aren't experiencing it are also those with the more rare phenotypes of PMOS. So people with insulin resistance, to explain this more, have built up a tolerance to insulin, making the hormone less effective. As a result, more insulin is needed to persuade fat and muscle cells to take up glucose and the liver to continue to store it. It is a metabolic condition. And in someone with PMOS, this hyperinsulinemia, or the insulin resistance, drives excessive ovarian androgen production. So it's kind of a loop. So what works to support more insulin sensitivity? This is where I think we can say, here we have really actionable steps, validated, actionable. We see them function well in the literature to improve insulin sensitivity, which is going to impact so many of these different manifestations in someone with PMOS. The first is weight loss when appropriate. It's kind of a womp womp, but it's also kind of what the literature shows, that losing around 7% of body weight can improve insulin sensitivity for a lot of people. And I believe, I know that feels antithetical to everything else I've said here, but hear me out. Weight loss can be a byproduct of what else we're going to talk about here. The second thing, early meal timing and prioritizing protein early in the day. Now, protein emphasized early in the day for someone with insulin resistance, and earlier in each meal can help increase incretin hormones like GIP, GLP-1, but naturally, not the medication, which is associated with better glucose regulation and hunger management. These incretin hormones, they function with our circadian rhythm. So this is tied to sleep, not fasting. Does that make sense?
Yep.
Like eating protein earlier in the day is tied to your circadian rhythm. I see this extrapolated a lot to intermittent fasting is what people should be doing for PMOS, and that's just not accurate whatsoever.
Yep.
So eating protein earlier in the day. When we had our power hour with my team, one of the questions we asked Whitney at the end was, okay, you have a client with PMOS. What's one thing you would tell them to do? And she said, first meal of the day, 30 grams of protein. Eat that protein before you incorporate any carbs or fat. And then make your first meal of the day lower carb and increase carb intake across the day. That is what follows this these recommendations we know around improving insulin sensitivity. So second thing, early meal timing and prioritizing protein early. Third, shifting fat quality to more unsaturated fats and fewer saturated fats. It's almost like it's stuff we want to do anyway, right? Imagine that.
Yep.
But that's a big plug for food quality, right?
Yeah.
And the fourth thing is shifting carbohydrate quality to more fiber and whole grains. Fiber can actually modify the action of glucose and improve cholesterol response in our bodies. And this diet composition, I guess what we're calling it, can impact insulin sensitivity independent of weight loss, which matters a lot here. So we just had an episode, or I guess when we're recording this, our last episode to go out was about macronutrients. And what we talked about so much in that episode, Michael, was like, it's important for us to understand what macronutrients are so we can be more informed in our food choices. And this kind of adds on top of that, right? We're talking about protein, fat, and fiber. We're talking about protein, fat, and carbohydrates and how we can kind of manipulate our intake to be more supportive of this insulin sensitivity we want. So we're not talking about no or low carb here. We're not talking about intermittent fasting. We're talking about a definite focus on food composition that makes a big difference.
It's really funny, isn't it, how every episode we come back to these very sexy, not boring basics, Kate, where like if everyone just nails these basics, like 90% of your progress, in air quotes, can actually be found by doing that, keeping it super, super simple. But it's not very exciting.
I would say, I think, and I've worked on this with some of my clients, like we've tried to make this a little more exciting by like really making that protein first thing in the day, like the full focus and challenge for the morning. And then by like setting fiber targets and things like that. I get it. I'm trying to make it sound better than it is, but like, but it's effective.
Yeah.
And so
Yeah.
we can do the sexy stuff and just waste energy, or we can do the effective stuff
And actually feel better.
and actually feel better. Now, I need to wrap this episode up, but we cannot continue this conversation without talking a little bit about medications. I have seen so much of the conversation around this PMOS name change say, this is a shift to push more medications. This is a shift to buoy the GLP-1 industry, as if the GLP-1 industry needs a buoy. This is a shift to roll out a new peptide. I don't know, maybe. There's there are legitimate critiques to be made about pharma and access and bias in prescribing and the way women's health gets medicalized. Absolutely.
Yeah.
Sure. Is this our biggest concern around GLP-1s? I don't think so. No. Here's what is already being used in the medication world and why. Metformin. Metformin is a drug commonly used for those with PMOS to help treat insulin resistance. And from what we've learned, that is something that is prevalent for many with PMOS. It can help improve blood sugar regulation. It can help periods become more regular, and it can improve androgen-related symptoms for some people. Not everyone tolerates it well, but it is a common option that has been around for a long time. I know I have multiple clients on metformin who also have PMOS, PCOS. Birth control. Birth control is often the first line of defense in conventional care, especially if someone's main goal is like cycle regulation. Is this always a good thing? I don't know. I could make a whole episode on this. I think for some, it is a really helpful stabilizing tool. And for others, it's the equivalent of like slap a Band-Aid on it.
Yeah.
Band-Aid. So I think it's worth naming that it can be helpful for some, but also really incomplete for others.
Yeah. I know that Dr. Jen Gunter talks about this quite a lot because you see posts online, don't you? People be like, oh, contraception's bad. Don't ever use it. And it can actually be like a really effective healthcare tool that many people benefit from. And it's far too complicated to simplify things like that of saying contraception bad.
Absolutely. I saw actually yesterday a post saying, your birth control is a carcinogen. I was like, oh my gosh, choose something else. Go away.
Yeah, everything is now. I saw someone the other day saying people not to have mammograms because of the radiation. I'm like, oh my stop. Gosh. You stop, guys. Like these people are morons.
Stop it.
Yeah,
I know. Inositol supplementation. There is inositol, which is where, I think where the supplement world has something to offer.
Yeah.
Which I think, when people ask me like what supplements are real or whatever, I just usually go with creatine and leave it at that. I should add inositol to the list because it is true. Inositol, both myo-inositol and D-chiro-inositol forms can probably be a useful adjunct to the lifestyle pieces we're talking about. They appear to improve multiple symptoms and outcomes in those with PMOS, menstrual cycle dysfunction, hyperinsulinemia, and hyperandrogenism. There's a really great meta-analysis of a bunch of RCTs that support these kind of effects, and dosing-wise, you can see what's usually recommended. One thing about inositol supplementation is it takes time. Like a minimum of about 6 months suggested to really assess results. But
I've worked with some clients who found like great benefit from using that.
Yeah, absolutely. Yeah. It's been found to reduce abnormalities in glucose and androgen metabolism, but also improve fertility. So actually Examine has a really solid summary. If anyone wants to nerd out, we love Examine. And last, GLP-1s. This is obviously a topic that we talk about all the time, that I talk about all the time. And I feel like people are going to start being like, Kate, you're just a shill for GLP-1s. I'm not a shill for anything. If I was a shill for something, I would be rich, and I'm not. So I think that I've seen these freakouts as if like this is going to get more unqualified people on GLP-1s, but like that's not our issue. I don't think that would be misuse. If PMOS is a metabolic and endocrine condition, it makes sense that medications affecting metabolic pathways would be on the table for some people, right? there already is literature around GLP-1 usage in those with PMOS. And obviously it's going to depend on the different manifestations and your symptoms and blah, blah, blah. But I think like I have a goal here of like, let's nip it in the bud right now that this whole name change was about just hyping up the big pharma industry. This process started 14 years ago. I don't think we were thinking about GLP-1 usage in the way that it is used right now. And if GLP-1 usage becomes promoted more for those with PMOS, like that's the least of our worries in terms of misuse. That actually feels really relevant.
I mean, that's what a shill for GLP-1s would say, Kate, as you're sat
That
there
is
on
what
your
she
stack
would
of money
say.
like Scrooge McDuck. It's
Show me the stack of money, Michael.
Turn the camera around, Kate.
Show
Turn
it
it
to
around.
All right, I'm going to try to wrap this up. I hope this has been helpful for some. PMOS is a more accurate name for what we've been calling PCOS. It's a condition where hormones and metabolism interact differently, affecting ovulation and androgen levels and impacting long-term metabolic health. The old name centered cysts that aren't even cysts, and it really helped keep this condition, helped is the right word there, but it kept this condition stuck in a very fertility-focused box. And I think the narrowness of that box has really real consequences in stigma, in delayed diagnosis, in misscreenings, in people walking around feeling broken when they're not. So my goal here was to educate a little bit more, and I'm going to start using PMOS. I don't think the acronym will necessarily fix care, but I do think the accuracy of it matters and is hopefully going to help those with this condition feel better, but also because I want this condition to be taken seriously as a whole body endocrine metabolic issue that it is.
Love it, Kate. Nailed it. I just think with how prevalent this condition is, I think we all have a little bit of a duty to understand it a bit better. So I think you've absolutely nailed it there. I feel more informed. If you listen to this episode and you benefited from it, think anyone else who maybe has this condition or wants to know more about it, please do share the episode with them, and we'd really appreciate it, guys. And any questions as well, reach out. Kate has a lot more research on this paper that she couldn't fit into the episode, so she would love to share it with you.
Always. Thanks everyone for listening.
See ya.